Good afternoon, everybody. Hello and welcome. Thank you so much for joining us this afternoon. I trust that everybody had a really wonderful opening party and first day in Bali. For those that went on the hospital tour, I hope you found it really, really valuable this morning. Just to reintroduce myself, my name is Paddy and my offsider Mark over here. On behalf of EMS Conferences, I'd like to extend another very warm welcome to you all to the Bali EMS Conference. So thank you for being here. I would like to make a very special and offer a very warm welcome to our Bali-based doctors and emergency clinicians who are joining us today locally. So thank you for being here. This is such a wonderful opportunity for us to collaborate across borders and networks. So really appreciate you all being here. So this is quite a full week and we will try and run on time as much as possible. So we're just running a couple of minutes behind today. But so there'll be minimal breaks between the sessions, but do feel free to head on out to get a cup of coffee or some food. It will be available for the duration of the sessions, so please feel free to move about. Toilets are just out here to my left and down this corridor, or back down the stairs if there is an emergency. Obviously, we'll just follow the directions of the wonderful Trans Resort staff. There is a special table for special dietary requirements outside, so please make sure you find that if you need. I'll just reiterate as well, just with regard to the e-learning, please be advised that those links will be available for the next 12 months. So that is a choose-your-own-adventure race with your e-learning. The e-learning session that's time-tabled for this afternoon, you're welcome to stay around, but it's a non-facilitated session. So feel free to stay around and chat and network with your colleagues, but it won't be facilitated. As I said, the e-learning is to do in your own time. Just a reminder for our ASIM and ACRIM members to make sure that you sign in using the QR codes either in the book, in your event book, or at the registration desk outside. And at the end of the week, the wonderful team at EMS Conferences will log those hours for you. I do have to please just remind everybody, there is a photo competition ongoing, and so if you could start to tag EMS Conferences in Instagram, you'll go in the draw to win some wonderful door prizes, and that will be kicking off starting tomorrow. But without further ado, I'd like to get started on our first presentation this afternoon, and I'd like to extend a very warm welcome to Dr. Laura Ehlert based in Melbourne in Victoria, who is a paediatric emergency physician and the Director of Paediatric Emergency Training at Northern Hospital in Epping. Please make her feel very welcome. Welcome, Dr. Laura.
How about now? Excellent. Good start. So, hi, I'm Laura. I'm a pediatric emergency physician in Melbourne, in Australia. I work at two hospitals, the Northern and the Austin hospitals, and we see a lot of children there and a lot of toxicology presentation, hence my talk today. This is my second time talking at an EMS conference. And I'm very humbled and delighted to be invited back. It's a great experience because I love the mix of people attending. It's great to see nurses, paramedics, and doctors all together. So I'm very happy to be here. I would like in my talk to start and talk a little bit about pediatric differences in toxicology, pediatric quirks, how we perform a pediatric assessment, and then talk about some cases. I'm not quite sure about the acoustics of the room, but if you want to answer questions and just shout out, we'll see how that works. All right, let's get started. So The dose makes the poison. Paracelsus famously said that, and I'm bringing him up because he was the father of toxicology. He was a Swiss physician, philosopher, and alchemist, because it was back in the 1600s. But he was the first to recognize the importance of the dose and how substances or elements can be toxic or not according to the dose, and if they can be used therapeutically. His actual name was Philippus Aurelius Theophrastus Bombastus von Hohenheim. I had to write this down because I don't remember it. And he was a very modest man, so he called himself Paracelsus, which means beyond Celsus. Back at his time, Celsus was idol, I guess, a very famous Roman physician who was very well known and very much quoted at the time. So he was beyond Celsus, so he was even better than Celsus. That's why his name came about. And this is my favorite quote of his, after the dose makes the poison, of course. And he said, whether wine is used as nourishment, medicine, or is a poison, is just a matter of the dosage, which is pretty much the essence of toxicology. So just some examples from everyday life about different things that we use very innocently so, and that can actually be quite toxic in large dosages. So apple seeds and also almonds contain amygdalin, which is a substance that can produce cyanide in the body, so that can be quite toxic. Pears contain a very small amount of formaldehyde. Potatoes, especially if they are green, contain solanine, which can cause gastrointestinal irritation and, in extreme cases, seizures and coma. So don't eat green potatoes. And courgettes can be quite toxic as well. This is a pediatric talk, so let's look at the differences in small people. So it's stating the obvious that their weight is smaller, so they can be more affected. One of my toxicology teachers said if a child gets bitten by a snake, the snake is going to give the same amount of poison. The snake doesn't know that it bites a child. So smaller weight, definitely important. The BSA is proportionally larger, so that can be significant in toxicological calculations. The skin is thinner and more prone to absorption for certain toxins. The airways are smaller, so they are more prone to bronchoconstriction. And there is a different volume of distribution. So all these are very significant changes in toxicology. And also the minute volume is greater, so this is significant with inhalation injuries. The kidney and liver functions are quite immature, which affects elimination. And they are generally more prone to hypoglycemia, which is also valid when they are sick without being poisoned. And looking at the very little ones before they are born, a lot of medication can cross the placenta, so that's significant in poisoning in expectant mothers. What other pediatric considerations are there? Exposure is often accidental. So just be mindful when the parents come to you. The kids are curious, they have taken this medication. For the parents, it's already the worst day of their life. So education is important, but just be gentle and mindful because they are probably already feeling horribly guilty. The usual age that we see with accidental overdose is between 1 and 5 years old. If they are, we always have to think NAI, or non-accidental injury, at the back of our head in pediatrics. So especially if they are outside this age range, if it's an intoxication or poisoning with multiple substances, or indeed if this is a recurrent exposure, then consider NAI even more so. Disposition in pediatrics in general is going to be more conservative. So especially if they present in the evening, we rarely send our little patients home. We keep them in overnight for observations. So we are much more generous with our time. Other pediatric consideration. So we have some examples of vapes there. What do they look like to a child? They look very inviting even to me. My first thought is, this is candy, this is gonna taste great. Sugar, let's eat them. So keep in mind how medications or other substances are presented. Kids are very curious, they like to explore. This looks like candy, and most of them also smell delicious, so kids are very likely to ingest them. It's very attractive to them. And just think of the family setup as well. What is actually accessible to the child? Children are obviously often at home with their parents, especially when they are young, but they are sometimes with grandparents and friends, and they may have limited medication storage knowledge available to them, and kids are more prone to take something that they shouldn't, so keep that in mind. And sometimes it is just something opportunistic that was available and they took it. So I think this is pretty well known. The shortening we use for it is RSI dead. So at least that's what we use in exams to remember the steps we need to go through. It's a useful way of just remembering what we have to do when we assess patient with a toxicology presentation. So we start, as always, with resuscitating them. So look at the ABCs, detect and correct any abnormalities, things like, is their blood sugar low? Do we need to replace that with an emergency antidote, something like dextrose, for example, for hypoglycemia? Things that we do in the very initial period. A risk assessment, then we would look like what exactly was taken, do we know the dose or can we assume the dose, how many agents were there, and anything else about the child, when was it taken, do they have any other medical problems, do they take any medications on their own, what other relevant factors are there. Supportive care, so we would look at what we need to do for the patient. Is this something where they are likely to deteriorate suddenly? Is it something that's likely to require intubation or airway support? So we try to assume as much as possible and get prepared. Are they gonna require hydration? Investigations, I think ECG, paracetamol level, and BSL are done, at least in our hospitals, pretty much routinely for every presentation, especially when they are not sure what they took. And then we'll talk a bit more about how do we make the poison get out of the system quicker? Can we decontaminate them? Can we enhance elimination, make it pass through the system quicker? Are there any other specific antidotes? And what do we do with our patient at the end of all this? So resuscitate them first, like we said, airway, breathing, circulation. With the circulation, I do like simple things to remember. Emergency physicians, also pediatric ones, like simple diagrams that they can remember easily. So mainly look at the blood pressure and heart rate. Are they abnormally low? Are they abnormally high? And it can give you a bit of a clue about what's happening. Obviously, keep in mind that children, especially little ones, have different heart rate and respiratory rate and blood pressure values to adults, so it needs to be normal or abnormal for them. It may be abnormal for an adult anyway, so keep that in mind. So what do we do next? So like we said, detect and correct. We look for the few obvious things that we act on quickly, and this is by no means a full list, so there is always something else that we notice or can do. So treat hypoglycemia, which is quite common in pediatrics. Obviously, if they are seizing, treat that, and look for hypo or hypothermia. And use emergency antidotes. Naloxone, unfortunately, we do need to use it relatively often in our pediatric population. Dextrose for low BSL, sodium bicarb or atropine, and obviously there is a much longer list of antidotes that are available that I'll get to a bit later on. What I would say with toxicology, often we think you don't have to beat the drug, you just try and know what it is and how to outlast it, just what treatments you need to give, how to make the child last until the drug is out of the system. So there is pretty much always an endpoint in sight that you just need to get to that point and the child will get better. And I'm not sure about the local setup here in Bali or in other countries. In Australia, we are very fortunate to have a very good poison information line that is staffed with people that have done some basic toxicology training, and then if it gets more complicated, you get put through to a toxicologist. So in complicated cases, we are fortunate enough to always have access to a toxicologist to guide us further. So then risk assessment, what else do we look at? So we look at what agents were taken, and sometimes we know, sometimes we don't. We have had a case of a child whose parents bought on the equivalent of eBay or Facebook Marketplace or whatever it was, an old chest of drawers, and one of the drawers had some tablets in it that the child took thinking they're lolly. So it turns out they were Viagra tablets, so you never quite know what's going to walk through the door, but the parents certainly didn't know what it was. So there is a MIMS pill identifier, so it's MIMS, and one of the options it gives on the website is a pill identifier, so you can talk about the size, the color, if there are any letters or anything else, any lines on the tablet, so that's quite useful if you don't know what it is. And for agents that are non-pharmacological, and I've only just found this out, but apparently if you don't know what they are, but you have some packet, some description of what it is, and put it in and then write MSDS, it may or may not give you some indication. It's apparently mainly Australia-based. So if it's something foreign, it may not work, but it's worth a shot if it's something non-medical that you want to identify. The dose in pediatrics, sometimes it's clear, most of the times it isn't. So you would have a little child come to you that has maybe managed to open their paracetamol bottle that was full of syrup, and they took some because it tastes nice, but there is also some on their face and some on their clothes and some on the floor and maybe some left in the bottle, and no one can remember if the bottle was new or old or how much was missing. So essentially in pediatrics, we assume worst case scenario and go with that. If there is something left in the bottle that's clearly not taken, but we hardly ever make any assumptions how much is on the clothes or how much is on the floor. So if it's missing from the bottle, we just assume it's in the child. Luckily, many medications don't taste great, and little kids struggle to take tablets, but there are other telltale signs, like do they have tablet residue in the mouth? If they vomit, is there any tablet residue in the vomit? So you try and ascertain as much as you can about how much was taken. And then other important things would be how much time has passed since ingestion. So have they developed symptoms or not? Can you be reassured or not? Is it a slow release preparation, in which case you need to watch them longer? If you talk to a toxicologist, they will always want to know the weight of the child, because obviously it makes a difference in how the dosage taken affects them. Is the child otherwise well, or are they already on some medication that may interfere with what was taken? Are they showing any clinical features, and how are they traveling through the progress of this illness, of this overdose. So, supportive care. If we expect complications with severe poisonings, ideally, and it's always a fine balance, but ideally, if we know they are highly likely going to need to be intubated, it should happen as early as possible, ideally before they drop their blood pressure, before they are cardiovascularly unstable and you're going to struggle a lot more. So with, for example, with calcium channel blockers, if they start to drop their GCS and it looks like they're starting to go into a coma, it will be very difficult to intubate because they drop their GCS last. So their cardiovascular system is already affected and it's just going to be very difficult to intubate them safely. So keep in mind what's the expected progress with what they have taken. Anticipate agitation and delirium if you can, and try and treat them to keep them comfortable. If it's a prolonged course while you wait for them to recover, don't forget to hydrate them. And then monitor them for the appropriate period. So things like beta blockers or tricyclics, antidepressants would show symptoms in, say, 2 to 4 hours. Something that's a sustained release preparation can be much later, so some are even 6 to 12 hours. Always, I don't remember all the drugs. I don't think anyone does. Always talk to your toxicologist. They will be able to advise you how long to wait, how long to observe them for. So investigations, we have mentioned some of them. ECG, we always do. We always check a blood sugar level and paracetamol levels. And then, obviously, if we can cannulate a child, we'll take all the blood that we can for anything else that's appropriate. Quite a few medications you can check drug levels on, and it's useful if you know what the timing is after the ingestion when the bloods were taken. And just talking about ECGs, obviously we are not going to remember all the changes, but just important to know a few of the main ones and just be able to establish, again, knowing the child's age and expected heart rate, what's normal for the child, what's a tachycardia, what's a bradycardia, and look at some typical ECG changes. Is there QT prolongation or not? What is the tachycardia like? Is it wide complex or narrow complex? And that may give you some clues. And then the last part of our algorithm. So decontamination, very important. I will talk about charcoal a little bit more in the next slide. We don't induce vomiting anymore. We don't use ipecac syrup or anything like that. But when we say gastric elimination, we mean charcoal, activated charcoal, or whole bowel irrigation. So whole bowel irrigation, I don't know if many of you have done it or seen it. I think everyone hates it. It's a complicated process, especially in children. You have to put a nasogastric tube down and essentially flush them until, well, hopefully everything comes out. So I would just be mindful what we use it for. So I would use it when charcoal is definitely not useful in things like heavy metal poisoning, iron or similar things. In older children, if they've been abused as body packers and have swallowed packets of illicit drugs, or medication with sustained release. So that's one or some of the indications we can use it for. Enhanced elimination, so we can use multi-dose activated charcoal, so we keep repeatedly giving them charcoal, urine alkalinization, or hemodialysis or hemifiltration. So we would use those for drugs like carbamazepine, phenytoin, and of course salicylates. If you use antidotes, keep in mind it's not just about giving the antidote and that's going to fix the problem. It's giving something that is a medication in its own right and can have contraindications, can have severe side effects. So again, be mindful about when you give it and how much you give. And disposition, there are always lots of factors to consider. What's your hospital like? Does the child need a setting like HDU or pediatric intensive care? How long are they going to be watched for? What actually happened? Do the parents need support? Does the child or the parents need a mental health review? So take all this into consideration before discharging. Charcoal can be an interesting medication to give. It doesn't look very appetizing. It just depends how you sell it to a pediatric patient. If they're still reasonably well, you may tempt them saying it's Batman ice cream, so you can mix it with ice cream, you can mix it with juice, and charcoal is black. The tablets or whatever preparation you have are black. But if you sell it the right way, if you bring Batman into the equation, it may work. Charcoal is normally quite sweet. So we have a terrible habit in peds of actually trialing tiny bits of the medication that we give, just so we know what we expose our patients to. Charcoal is remarkably okay. Flucloxacillin syrup is not. So if you ever have a child that's spitting out and refusing to take it, they are justified. Do not force it on them. So hopefully you can get some charcoal in. Ideally give it within 2 hours after the ingestion, or if it's a sustained release preparation, you can go up to 4 hours. Talk to toxicology if you're not sure. It can be used as single or multiple dose according to the presentation. And there are certain drugs which I've listed that it just doesn't work very well with, so I probably wouldn't give it in those presentations. So things like an iron overdose, hydrocarbons or essential oils, it just doesn't work very well. It doesn't bind them. So this is just another list, which again, the list can be 3 pages long, but you know, I need to keep you guys interested in the talk and attentive. So just a few common examples of what we can use and what we have available. So think about it and use it appropriately in your pediatric patients. And this is just a reminder of the common toxidromes, which are very similar in adults as well. Pediatrics is just the same. Keep in mind when you do your patient assessment, look at the heart rate and blood pressure, which hopefully gets measured on arrival. What's their respiratory rate like? How are they doing otherwise? What are their pupils like? Can you hear bowel sounds? That's a tricky one. ED, at least our ED, is such a busy environment, I can almost never hear bowel sounds, even if they are there. And are they sweaty? Are they tachycardic? Are they hyperthermic or hypothermic? What do they look like? So let's look at some cases. Any questions so far? So I'm very happy for the cases, at least to be interactive. So if you think what it is, shout it out. It's great if you know. I don't mind if you give it away from the first slide. That's fine by me. Probably. So, which is a good reminder. So that's great. So it's a good reminder. We always check the BSL in children. So grandma, that already we know what's happening. This little one has taken the grandma's medication, hasn't he? He was well this morning. There was nothing else going on. Looks pale, lethargic, and then has a seizure. And since we know he's hypoglycemic, he is hypoglycemic. His BSL is 1.9. And grandma says he was playing in her bedroom just before this happened. She doesn't think there is anything much there. But wait, maybe her purse was in the room, and maybe her medication was in the purse, so maybe he has taken something. What did he take? Sorry, I can't actually hear you. So, say this, if this is what you guys say. Sorry, I can't hear them very well. There are a few other drugs that can cause it, metformin being one of them, but this is the most common one. So medication like glycoside that a lot of grandparents are on. So they stimulate insulin secretion in the pancreas, and the children become hypoglycemic. The symptoms of hypoglycemia in young children can be quite vague, so essentially remember to check. So what do? Obviously, we fix the blood sugar, and remember, complex carbohydrates are better. So if they want a lolly, sure, but a burger or sandwich would be better if we can get that in the ED. If we can't get their BSL up, then we need to treat them with octreotide. And if that doesn't work and we need to continue the infusion and the hypoglycemia persists, then we give dextrose as well. It's a drug that takes forever to get out of the system, so you need to watch them after they stopped being hypoglycemic and they stopped needing treatment. You need to watch them for at least 12 hours. So let the grandparents or the parents know it's going to be a long admission. And as always, don't discharge them at night. Okay, so this is a 1-year-old girl, so they are all in the right age group. She presents with mom. She's very distressed and very agitated. The mom is saying she was dropped off by the father at the mom's place about an hour prior to the presentation. And the parents are separated or divorced, and the mom is saying she has been poisoned by her father and wants a drug screen. If you have done a little bit of pediatric CD, it's not that uncommon. You would have seen this. What do you do next, and what might have caused this? What could it be? Yes, so, yeah, don't know exactly what, but probably one of these. So then there are a few things we need to keep in mind. Was it something, did the father poison her on purpose? That is not our call to make. We need to treat the child in front of us. Was it something that was an illicit drug? Then it may be mixed with something else, and we just need to be careful what else could happen with the child, what other effects this could have. It could be something prescribed, so it is prescribed for conditions like ADHD, so the father may be on this medication. It is one of the most distressing presentations in a child. They are genuinely upset and inconsolable, and it's actually terrible to watch. And they have, if you remember the toxidrome list, she shows all the signs that we've spoke about there. So her pupils are dilated, she's tachycardic, hypertensive, she's sweaty and hypothermic, and she just doesn't look good. So we need to treat her agitation, so just slowly titrate benzodiazepines and try to get her a bit more comfortable. I put it on the last place on the slide, but it's probably important to consider other diagnoses early. Listen to the mother's history, but you really want to make sure this child doesn't have encephalitis or meningitis or something else terrible. So the hypothermia could be a side effect, but she could also genuinely have a fever and be just toxic and unwell. So I would, in this case, I would treat with antibiotics anyway. She is going to be admitted. Urine drug screen, that's a tricky one. So we need to consider, yes, it can be done in the ED, but it only tests for limited number of substances. We can't test for everything. And obviously, if we treat with drugs like benzos, that's going to come up in the drug screen as well. And then we need to understand why we do this drug screen. If it's done for the police, then what we do in hospital is probably not relevant for them because it needs to be taken in a certain way and it needs to satisfy their criteria. So if mom has all this concern, it is best she speaks to the police. What we need to consider if we have any other concerns is the child safe reporting. And remember, we don't know what's going on with the family. We are not making a call if someone is guilty or not. We are just notifying a concern. We are concerned this is a child at risk with our best judgment from what we can see. And that's exactly what I would notify. So, and I think this is quite concerning, and someone else who's not an emergency doctor needs to sort all this out. In Victoria, we also have a service of forensics called VFPMS. So if there are any other abuse concerns, we can discuss it with them. And if they request a drug screen for any other reason, then of course we can accommodate that. Okay, let's move to another case. So this is also a little 2-year-old. He is quite unwell, agitated in the ambulance initially. You get a notification. He's vomiting. He has a wet cough, tachycardic, hypertensive. And then he becomes very lethargic. His numbers change to bradycardia and hypotension. And he then has a respiratory arrest. What's going on with him? Potentially. So what are we talking about? We are talking cholinergic syndrome. So it is a 2-phase process. So in this little kid, it was due to ingestion of nicotine, which is unfortunately, I don't know, vaping is in a way more dangerous than smoking because it's completely unregulated, at least in countries where I've worked and come from. So when you buy the vaping, whatever it may be, little box, you actually have no idea how much nicotine is in there. So a child drinking that can easily be poison and it can easily be fatal, unfortunately. And there are lots of other substances mixed in there that no one quite knows what they are, and it's not regulated in any way, so it's impossible to find out. So you don't know what a nicotine concentration is, and it is famous for having this 2 side effects, so the clinical presentation changes according to which receptors are affected. So there is an early phase and a late phase, and that's exactly what he's showing. And again, it is quite a distressing presentation. He did well, though. So attention to ABCs, give atropine, give diazepam, intubate if muscle weakness, and if there are no symptoms at 2 or 3 hours, especially GI, then it's hopefully, probably okay. And just to show how clever children are, we had a little boy presenting to ED who managed to find some Nicorette, which is to cease smoking, tablets in his dad cubbyhole in the car. The dad was distracted on the phone. They were waiting for an appointment. The boy was playing with the box, managed to open it, and took some tablets. No one knows how he opens it because the dad presented to our emergency department with the boy and the box. And there is the luckily happy and unaffected toddler, but there is the father, 2 triage nurses, and myself trying to open this box, and none of us could, but yet the toddler opened it. So they are very clever. Okay, we have a couple more cases. So a 6-year-old presents with grandma again. This time we know what it is. So she was found in the grandma's bedroom playing with a verapamil bottle, slow release, 180 milligram tablets. Grandma thinks at least 2 capsules are missing. The child is currently well, has a normal behavior. Grandma wants her stomach pumped. What do? She's very well. Sorry? They have taken 2 tablets, yep. So in this case, this is true, yep. You've done all the detective work. Do you let them go home? No. So this is actually very dangerous. So verapamil is one of the true one-pill kills, together with diltiazem. They are negative inotropes, and they cause profound cardiogenic shock. And it's actually quite distressing because the patient remain cognitively well until the very end. So that's one of the examples where if you wait for them to become comatose, their cardiovascular system is pretty shut down, so very difficult intubation and giving medication. It can cause hyperglycemia and insulin resistance as well. So if their blood sugar starts dropping, that's actually a good sign. Obviously replace it, but it is a sign that they are getting better from the overdose. So look after the circulation, which is a priority. Early intubation. If you give charcoal, see what a child is like, but you can give charcoal through an NG tube where the position has been confirmed by a chest X-ray. So a good antidote is the high-dose insulin euglycemic therapy, and it's quite specific for calcium channel blockers, and it acts as an inotrope. And then adrenaline or noradrenaline, or both, whatever you need to keep the circulation going. Calcium can help, and if they are not getting better, consider ECMO. So clearly she's not going home. Clearly she needs an intensive care unit, so they are quite sick. Last case, so this is also a 2-year-old from home with a dad. Dad was working from home and trying to single parent at the same time, which it's not great with a 2-year-old. I had to do it with older children and still wasn't great. 2-year-old, I can't imagine. So the child doesn't look very well. He's pale, cyanosed, lethargic. His sets are 85. You get IV access, put him in resus, and the blood looks like chocolate. What is this? No clues, no ideas? So this is methemoglobinemia. It can cause by a number of medication, but also by naphthalene, which is in mothballs. So these little white things are not Mentos or candy. They're actually mothballs that the child found in the cupboard and took. I haven't tasted mothballs. I don't know how good they are, so I don't know how many the child took. But they can cause both hemolytic anemia and methemoglobinemia. So quite dangerous. The blood is chocolate brown because the hemine is already oxidized and can't bind oxygen. So what do? Methylene blue is the antidote, unless your patient has G6PD deficiency, in which case do not give it, because in G6PD deficiency, methylene blue causes, again, methemoglobinemia and hemolytic anemia, so it will make your patient much worse. So remember to ask that. Remember to look at the VBG if you do one all the way down. Our printouts are about this long, and I've been guilty of just checking sugar, lactate, pH. Okay, great, but actually look further down and the clue is there about what's happening to your child. Oxygen doesn't help that much, so, and just some guidelines about when to treat, but again, follow your toxicology advice. And then just some mentions about other very toxic drugs. So methadone can be very lethal, be careful. And you also need to report it because methadone is very strictly prescribed, and yeah, just all the follow-on from there, who had access to it and how the child got it. Amitriptyline, so tricyclics, again, very toxic. Bonjela, I don't know how commonly known it is, but in Australia is widely used as a teething gel. So for babies who are teething and you just rub it in their mouth, and because every parent and every grandparent has a tube and everyone gives a little bit more because the baby is crying, we have no idea how much they take, and it contains a fair bit of salicylate, so it can cause salicylate poisoning. So do not give it, is probably the advice. I don't think it works anyway. But yeah, that's the reason it's toxic. And then we had to put Trump up there with his hydroxychloroquine advice. Hydroxychloroquine is not used very often, obviously, but if it's taken by a child, it is actually very toxic. So be careful if you hear that. This is from the Don't Forget the Bubbles website, which if you haven't come across it, I'll put it up at the end as well. It's a very useful pediatric resource, and it has a bit of everything in there. So that's a good list of one pill kills. Obviously, some medications like theophylline are hardly ever used, but they are on the list nonetheless. Just a quick mention about essential oils. So we had a few cases recently. Again, it's something that smells lovely, and they now have some flavors that smell like cake, so vanilla and cinnamon and other things. So kids could take it. And it's actually really toxic. The oil is toxic and the hydrocarbons are toxic. And you only need to take 2 or 3 meals to be potentially lethal. So it can cause seizures and respiratory depression, and it's quite nasty. So worry if you hear they have taken something with essential oils. I wanted to put a slide with things not to stress about if your child or the parents present with this. PPIs, the oral contraceptive pill, antibiotics are all very safe. I don't advise taking them in an overdose, but if they do, probably nothing will happen. Vitamins, the same. Antiemetics, the only thing to mention is metoclopramide, which obviously causes a dystonic reaction, but that's not related to the dose. So you can take it in a therapeutic dose and get a reaction. It's not because you've overdosed on it. And homeopathic medication, I didn't know this, but some of them contain a little bit of alcohol. So your child may be a bit drunk, but otherwise no significant side effects. So, hope this was useful. Think about the different anatomy, physiology, and toxical considerations in pediatrics. Poisoning prevention and education is very important, but be gentle, especially with distressed parents. And some of them, you just look at them and you know, I don't need to say anything. This is the worst time of your life. This is never going to happen again to your child, and you're going to tell all your relatives. So. Don't call medication lollies, very important, how you present it to the child. And obviously, the older the children are, the more they move towards the adult spectrum, so their motivation may be different. This is a magnet that we give parents when they leave the ED, and just a few important reminders about medication keeping and safety, and just remember to check your medication box every now and then, see what's actually in there, and if you have some tramadol left over after an operation 5 years ago, you should probably throw it out. This is personal experience with my medication box, so yeah. Clean it regularly. And I use these resources a lot, so obviously if you know them, great. If not, see when you have time, have a look. Don't forget the bubbles is pediatric specific. Life in the fast lane has pediatrics and adults, and again, wealth of resources. And the Royal Children's Hospital in Melbourne also has guidelines for pretty much everything pediatric under the sun. You just go to the letter of the alphabet that you want, and it will, 99% of the times, it will come up. And that is me done. Any questions?
Thank you so much, Dr. Laura.
Thank you for having me.
Thank you so much. Some really valuable insights. I can testify that toddlers are Houdinis and will get into anything, and I'm particularly interested in Batman charcoal ice cream. So potentially we can get the recipe off you later. We'll just have a 5-minute tea-wee break for a couple of minutes. Be back here and ready to go for just after 3 p.m. for our next presentation. Thanks again, Laura. please make the most of the wonderful food that the resort has put on for us. We will get moving into our next session, our next presentation. Please welcome our next speaker, who is Viv King from the Associate Nurse Unit Manager at the Victorian Virtual Emergency Department. Please make Viv feel very welcome. Thanks, Viv.
Hello. Fantastic. Thank you all for being curious today about nursing in the Victorian Virtual Emergency Department. My name is Viv and I'm the Quality and Safety ANUM at the VVED. I've been a nurse since 2003 and I've worked in a variety of different settings, including aged care, general practice, rural acute and urgent care. I've worked on medical and surgical wards, in the emergency department, and now I'm in virtual health. I have a postgraduate certificate in critical care emergency nursing, and I have a postgraduate certificate in health service management, quality and safety. Today, I will share with you nursing in the Victorian Virtual Emergency Department, or the VVED. We will provide an overview of the service, including access criteria, pathways and service highlights. We'll share the nursing team and how this developed alongside service expansion and link that in with some data. We will consider quality improvements, we'll discuss challenges, and we'll look towards the future. Okay, so the VVED is a 24/7 statewide video consultation service in Victoria. We provide support to critical healthcare services, including Ambulance Victoria, the state's urgent care centres, the state's residential aged care facilities, AV secondary triage, and nurse on call. The point of difference with our service is that we accept self-referrals from the public, making us an accessible virtual care provider. Our aim is to enhance healthcare equity across the state, provide support to those critical healthcare services, and reduce avoidable ED presentations, and get the right patient to the right care at the right time. Criteria to access the VVED is the patient must be physically located in Victoria at the time of consultation. We do also provide support to our border towns. They must have a device capable of video consultation with stable internet connection. So we need the device to have a working microphone, speaker and camera. And this could be a mobile phone, a laptop, a PC or a tablet. The patient must also be physically present and awake at the time of consultation. And I know that sounds a little bit funny, but that one really is aimed at our paediatrics patients, parents and guardians who often register while their child is at daycare or at school, or it's 3 a.m. and the child's asleep and they're not willing to wake them. The VVED is here to see non-life-threatening illness and injuries, and these are our top-ranking presentation complaints. We've got limb pain and injury, rash, abdominal pain, nausea, vomiting and diarrhoea, fevers, and respiratory symptoms like shortness of breath and cough. Here's the pathway into the VVEDs. I know, very messy slide. In here, in the red, we've got, in the red, yellow and blue, we've got our healthcare referrer pathway. This is Ambulance Victoria, residential aged care and our urgent care centres. These patients are all with a healthcare provider, so they're seen directly by a clinician. Over here in what I call the green pathway, the self-referral pathway, the self-referred from home is the general public, and then we have nurse on call. These patients obviously don't have a healthcare worker with them, so they are seen by a triage nurse so that we can see them in order of their acuity. Okay, once the patient has registered with VVED from that self-referred pathway, the team that they will see will be a triage nurse who may be supported by a mental health nursing lead, an advanced practice physiotherapist, a nurse practitioner, a general practitioner, an adult and ped emergency physician, a geriatric GP, and maybe even a paediatrician. Before we look at the nursing roles, I want to share some highlights which we've celebrated since our service began in 2020. So in 2020, the virtual triage began as a pilot project at the Northern Health ED to reduce avoidable ED presentations in Victoria's busiest emergency department, especially at the height of COVID. At this stage, all of the patients were self-referred and they were seen by an ATS-trained critical care nurse who used a clinical decision support tool to help with their triage. In 2021, we partnered with AV to support patients to manage their care at home and get crews back out on the road sooner where we need them. In 2022, virtual triage became the statewide service newly branded as the Victorian Virtual Emergency Department. We also began averaging 200 patients a day, which was quite significant for us at the time. In 2023, our partnership with Nurse on Call began and we successfully passed our first accreditation. 2024, we went go live on our Fit for Purpose registration platform, which is affectionately known as Reggie. And we had organisational endorsement of our virtual triage tool. And this year, we passed the 500,000 patient marks. And as of today, we sit just shy of 680,000 patients, and approximately 45% of these have been triaged by a triage nurse. So that's 680,000 patients who have not gone to a Victorian emergency department. Nursing roles in the VVED. We've got our Director of Operations, Director of Nursing. We're very lucky for a department to have our own Director of Nursing. And Dave joined us in February this year and has provided that much needed structure and support to our ever-growing nursing team. Our Nurse Unit Manager, Ella. We have our Associate Nurse Unit Managers, which also consists of 2 unique portfolios, which is Quality and Safety and the Operational ANUM, as well as our clinical ANUMs. Our nurse education team, which consists of our clinical nurse educators and our clinical support nurses. We have clinical nurse specialists, virtual triage nurses, and nurse practitioners. We'll look at these roles now and we'll link in with some data and you can see how our nursing team developed alongside service expansion. So our Nurse Unit Manager was first appointed in January 2022 when the daily patient average was about 106 patients a day and 30% of these patients were being triaged by the nursing team. The Nurse Unit Manager was essential in moving the virtual triage project into that statewide VVED. The NUM established working from home for triage nurses, which opened up recruitment across the state and brought back many experienced nurses back into the profession and into virtual health. Ella is currently working on expanding the nursing role into the virtual ward, which is called the Virtual Observation Ward. Our education team. Our first clinical support nurse was appointed in April 22 when we were averaging 160 patients a day, 55 of these having been seen by a triage nurse. The original clinical support nurse role was to orientate nursing staff to VVED and train them in virtual assessments and how to undertake triage using that clinical decision support tool. We now have 3 CNEs who develop training and education programs, orientate new staff and support the 7 clinical support nurses who provide that real-time on-shift support and training and education to 157 nurses. Not long after, in June 22, our nurse pracs committed to providing overnight medical coverage. Yes. Elevating our service into that 24/7 care model, and they remain the backbone of this model today. Our NPs are made up of paediatric specialists, geriatric specialists, general ED, and we have a dedicated diabetes nurse prac. 2022 was a huge year for our nursing team and for our entire service. And in August, our first group of ANUMs were appointed. The role sets the clinical and professional standard in the VVED. It prioritises safe communication in the virtual setting, embedding communication standards into the service. Something as simple as huddles, which are delivered by ANUMs 12 times a day. They act as a clinical and operational resource. They are a point of operational escalation, and they have full department oversight, including 7 different waiting rooms and our registration platform. They build standardised workflow processes which are continuously updated in our dynamic service, building safety and quality into day-to-day business. At current, we have 15 ANUMs, 2 developmental ANUMs, and 3 nurses trained as nurse in charges, and this role remains the pillar of our day-to-day operations. We'll look now at the 2 unique ANUM portfolios. Oh, there I am again, double trouble. So fast forward 12 months and we're now seeing 352 patients a day. We're now on par with our local ED service. The role of the Quality, Safety and Patient Experience ANUM was appointed to support the NUM originally in a bit of procedure writing, clinical incident review and management of consumer feedback. And as the service grew, so did this role, which now includes quality, safety and systems development, implementation and monitoring, accreditation readiness, data analysis and reporting, risk and incident management, continuous support to continuous improvement projects across the department, and managing all consumer feedback, audit building and coordination, but most of all, advocating for our patients, advocating for their safety and advocating for our worker safety. We had a pretty steep climb in patient registrations, and 9 months later, our patient volume had doubled. And our service was expanding, and our NUM needed some more support with day-to-day business, and hence, the operational ANUM was appointed. The core role of this portfolio now includes all rostering of 157 nurses, which I think is equivalent to about 70 EFT. Recruitment, workflow process design, implementation and monitoring, and the Ops ANUM is a resource for operational changes and escalation. Our triage nurses, we couldn't do it without them, and they've been there since the beginning. To be a virtual ED triage nurse, you must have 4 years post-registration experience with recent experience in ED, ICU, or acute med-surg. Our triage nurses undertake assessment using the gold standard A to E approach, using a modified triage scale, which is known as VATS. Here's some triage presentation data from August 24 to August 25, and it's roughly 200,000 patients. And you can see that we've been able to maintain a steady diversion rate of greater than 80%, but we'll drill down on this data a little bit further. So looking into our triage data, we can see the category allocation percentage here. 11.6% of patients are referred directly to ED as a category 1. 13.1% of patients are a VVED priority review as a category 2. 55.5% of patients, yeah, it has that up there, are for a VVED clinician review, which could be with a GP or with a nurse prac, and 19.8% of patients are a category 4 and are referred back into the community. So that could be to their local GP, their local pharmacist, to a Medicare-funded urgent care clinic, which was a priority primary care clinic, or for our rural patients who have difficulty accessing further healthcare, we can see them in our sister clinic, which is called the Rapid Access Clinic. And as you can see, over half of our patients are triaged as a category 3. It's not surprising. Current literature supports that this is also reflective of physical ED triage practices. We wanted to provide further support and increase triage accuracy at VVED, and after surveying our nurses, we found from 60 respondents, which is about 50% of our permanent nursing workforce, that while our nurses feel confident in their triaging ability and are satisfied with the level of support that they receive, there is still that element of concern that they will miss those patient red flags. So we said, how can we help? And they answered, They wanted clearer triage definitions, which is currently undergoing iteration, and development of further education to support that critical thinking in the virtual space. They wanted increased education and training on weekends, which has been implemented. And interestingly, they wanted to have a post-shift nursing discussion, like a roundtable where they could get together and share their day and talk about their patients and learn from one another. And nurses everywhere are advocates for positive change and are essential to quality improvements. And here are two major quality improvements which have been nurse-led. So one is reducing call abandonment rates, and the other is implementing a priority VVED triage category. We'll have a look at these a little bit further. In August 22, as the first group of ANUMs came on, we were tasked with reducing call abandonment rates, which had been sitting as high as 27%. In the July previous, they were sitting at 12%. So we researched call centre gold standards, and we found that the gold standard was 2 follow-up phone calls 10 minutes apart, with the KPI of reducing that call abandonment rate to less than 5%. So we trialled it. What have we got to lose? And by the September, we had a significant reduction to 4.98%. So not only did we show that this has improved patient safety, but we also reached that gold standard KPI. This was embedded into our procedure and remains part of our workflow processes today. And at present, our call abandonment rate for August was 4.3%. We do have further safety netting, which involves calling the patient's registered next of kin, or police welfare checking, or for those really high acuity registrations, we can initiate 000 for these patients. There's the results there. I think this has been the most service-changing quality improvement, and it was implementing a priority VVED triage category. So earlier I talked about the clinical decision support tool being used, and those categories were Cat 1 ED via Ambulance Victoria, Cat 2 ED via private car, Cat 3 suitable for VVED clinician reviews, so they stay in-house, and Cat 4 referred back to community services. And after receiving feedback from EDs that our Category 2 patients didn't actually require that urgent ED, we pulled some data. And we found that there was a likely high portion of these patients that could have been managed entirely in the VVED. So we implemented a quality improvement. And that was, after identifying that Category 2, we had a second step. Oh, I think I've got it. Yep, we had a second step put in place where we would trigger a notification to our emergency physicians or our paediatric emergency physicians that these patients were to be seen as a priority and that they needed to be seen within 10 minutes from triage. And here are the results. So 44% of these patients were referred into the emergency department with care management initiated. 55% of these patients were completely managed in the virtual ED and discharged to home. And 1% of these patients were discharged to other. So that could be direct admit to palliative care, a short stay unit, or a chest pain evaluation unit. This really laid the foundation of our fit for purpose triage system, which is known as VATS. And here is the improved scale. Category 1 ED via AV or private car. Category 2 priority VVED review. Category 3 suitable for VVED clinician review. And Category 4 referred back into community services. And nursing never stops when it comes to improving quality and safety. And these are our current nursing-led quality improvements, which include service capacity procedure, including surge call criteria. Like every other ED, our department swells and can almost feel like it's bursting. So we needed to put measurements in place which protect our patients and protect our staff from burnout. Thunderstorm Asthma Co-Brown Subplan. We have a mental health triage IAR decision support tool, which is in its later pilot phase. We've had a virtual health quality risk meeting committee come together. We found that there was opportunity to optimise our interpreter service, so that has now gone live. we're working on a sepsis recognition pathway with Safer Care Victoria, and we've just finished a specialised oncology triage package with Peter Mac. And as a new and dynamic and evolving service, we continue to meet our challenges with curiosity and with an exploratory mindset. And our continuous challenges include recruitment. With a rapidly growing service, staying on top of recruitment has at times been a real challenge. So to mitigate this, we opened up nursing recruitment statewide and nurse practitioner recruitment Australia-wide. Technology. We all know that technology doesn't always work, and we're no different in the VVED. We use multiple platforms to provide care to our patients, and these do have limited interoperability. So to mitigate this, our tech team have developed AI bots which bridge some of the gaps by pulling information from one site and placing into another. For example, from our registration site into our patient tracking list. It was very human heavy having all that admin to be done. And a remote workforce. We love working from home, but it comes with its challenges, and that is culture and connection. We are so lucky to have a dedicated ANUM group who are our social champions, who hold regular events in different pockets across the state to enable our team to have that face-to-face time and to get to know each other, which is so important. The future. Right now we're growing nursing into care coordination roles, particularly in the geriatric space, and into the virtual observation ward. We'd love to see nurse-led clinics like primary education clinics and chronic care management clinics. We would love to see a dedicated postgraduate certificate in virtual nursing, and my personal wish list is an Australian Virtual Nurses Association. We are expanding the nursing profession into virtual health, and we remain champions for our patients. We remain committed to continuously improving, and we are making a difference on our healthcare system and for our patients. And if I've learned anything from my time at VVED, it's that you can dream big and you can dream wild, because anything is possible, and virtual health is here to stay. Thank you. Hello, we have a question.
Thanks, Viv. Any questions for Viv?
Sorry, Gladys, but how many calls a day would you get directly referred from AV? Or do they not directly refer to you?
No, they do. Sorry, they do directly refer. I don't have exactly that data in front of me. I've got here 8.81% of our, from a presentation source of AV is 8.81% of our total calls. And our total calls can swell depending, like every other ED, depending on what day of the week it is. Wednesday's our dip, which sits at about 800 patients. Sunday is our height, which sits at 1,200 patients. Yeah. Our biggest referrer pathway is that self-referrer pathway, which in August sat at 62%. So that was that public and the nurse on call. Yeah.
One more over here, Viv.
Thanks, Viv. I'm an emergency doctor from Melbourne, and I found that a fascinating presentation. I must admit I had no idea the scale of the service and how much it's grown. So thank you for taking so much burden from us. I'm curious about one thing. In every emergency department, there's the phenomenon of frequent presenters. Is that a phenomenon that you get virtually? And
Yeah.
how do you manage that?
Yep, it is. That's a great question. And yes, we do have frequent presenters. And how do we manage that? We are with the Northern Health Organisation. So we use their pathway and their expertise to help us develop frequent presenter plans. And all of the ANUMs know the frequent presenters by now, so we flag it quite early with the nurses who are going in to say, hey, can you please read the frequent presenter plan located here? And we follow that. Yeah.
Thanks. And one more thing. Do you have any way of gauging how many of your patients would have actually presented to an emergency department if your service didn't exist?
Yeah, I don't know that data, but I believe that there is being a study undertaken at the moment to look at you know, how effective are we in terms of true diversion rates from ED? Yeah.
Thank you.
Thank you.
Was there another question for Viv? Yep. Stand by.
Hey, thanks for that. I'm a nurse practitioner in Auckland, at ED in Auckland, so really interesting stats. We do use a virtual, so for some of our patients we triage them out to a virtual clinic, which is interesting. Just wondering how this is funded, who pays for it?
The state pays for it, and I believe it is block funded. Yeah. I'm not really into the money side of business in virtual ED, with my specialty being quality and safety. So I'm not entirely sure, but yeah, it's paid for by the department.
Great. Any other questions for Viv? Coming.
Very nice percentage and calculation and follow-up you guys did. My question is, how you do your follow-up?
In terms of which
So
types of patients?
You talked at the end about the percentage of people going to the emergency department and then end up by resolve the problem or end up in another department. So how you do that follow-up, how you know your decision-making like skills of your nursing is doing the right thing?
Yeah, great question. We do a lot of auditing. We do a lot of auditing, which involves phoning our patients. There was a huge audit on our left without being seen, and that included, it's just man hours of pulling the data and calling patients and calculating that data and getting it all together. Yeah.
So you call the patient?
Not every single patient. It depends, I guess, on what the audit is following. Every patient does receive a survey after they've come through to us, and that survey has oversight by the entire leadership team. So it talks about, have you followed your plan? Were you happy with the service? X, Y, Z. Yeah.
So you started in 2022?
2020.
2020?
2020 was the virtual triage pilot, and 2022 we went statewide.
Okay, and no other state follow your steps?
I believe that there are other virtual models out there, but they are not entirely similar to ours. My understanding is we are the only state which sees self-referrals from the public.
Thank you. You guys are doing a great job.
Thank you so much.
Great. One more.
Thanks for that, Viv. I'm curious, so how does VVED differentiate itself from like Health Direct, another nationwide type service that does allow calls from the public?
Yeah, well, the difference is that we have our healthcare practitioner pathway, so we do support AV, all of their services, including their secondary triage service, the state's UCCs, the state's residential aged care facilities. We have also supported healthcare for the homeless, corrections facilities. So I guess that's what makes us different in terms of Health Direct. Yeah, I don't believe that Health Direct has doctors as well. I think Health Direct is Nurse on Call in Victoria, and that is all nursing led, and we're one of their referral pathways.
Thank you.
Yeah, you're welcome.
Thank you so much. We do, it seems like Victoria really is at the forefront of this. In Western Australia, we do have the West Australian Virtual Emergency Department, WAVED, which has a very cool name. But I can definitely see that Victoria is really leading the way in this space. So there's a lot that we can take away and learn from this. So thank you so much, Viv. Thanks for your time. Please thank Viv. Take 2 minutes as well, and we'll be back with our final presentation for the afternoon. Thanks, Viv. Okay, thank you very much, everybody. Okay, as we round out the afternoon, I would like to extend a welcome to our final presenter for this afternoon's sessions. So if you just join with me in welcoming from our nation's capital, Canberra, Australia's nation's capital, I should say, Canberra, Dr. David Banfield. Thank you, David.
The microphone is on. Can you hear me? Yeah, thank you. Thanks, Mark, for that kind introduction. So my name's David. I'm an emergency medicine physician from Canberra, and I am here to round out your afternoon. I can guarantee you I'll be done by 4:30 because I think all the beach clubs in Seminac are depending on your business. All right, so I'm a stickler for time. This is a really informal fireside chat. If you pick up 1 or 2 points from this to take back to your practice, that would be great. If you learn a lot, I would be very surprised. All right? A very informal foray on leadership, and I just want to touch on the concept of followership in acute care medicine, because I think it's a very underappreciated aspect of what we do. So very standard boilerplate disclosures, disclaimers. If anyone wants to fly me around the world and use my disclaimer list to advertise their business, feel free to get in contact. But I have no financial disclosures other than to say that I'm aggressively tax deducting this holiday in Bali. I work part-time as an MDO. I have a legal background, and so some of the content of this talk is informed by that experience when I'm assisting people when teamwork and situations have not gone according to plan. So a few comments on leadership. Leadership is a big deal in emergency medicine. There's a big focus in the literature. My trainees imagine that when they finish, they'll be in a crowded resuscitation room. There'll be 20 people there sort of carrying out all their orders perfectly. The patient will sort of exit the emergency department in a much better state than what they started with. Leadership is a very, very big deal. I don't have a problem with that, except to say that I think impliedly it does de-emphasise the role of each individual team member. And it's really the purpose of this talk to talk about the concept of followership. Because a superficial view of resuscitation team dynamics is that there is a dominant leader and that followers are really only task focused. And for those of us that have been in this business for any length of time, we know that that isn't really true, that followers have a very important part to play. Good leadership is important, and teams want to feel safe. Leadership can be about making people feel safe. And we have all been there in a resuscitation room when diarrhea is running down our pant leg and someone has walked through the door to take control of the situation and help us provide good quality care. But leadership is a little bit more than just making people feel safe and being decisive. History, unfortunately, is littered with dictators who initially made their populations feel safe, sometimes from invisible threats that they created. So making people safe, being decisive and being dominant is necessary but not entirely sufficient to be a good leader in emergency medicine, in my view. So with that said, there are some problems with a very leadership-dominant view on resuscitation team dynamics. One of the things that is worth saying is that not all problems in emergency medicine require a red cape and for you to wear your underpants on the outside, right? Most of what we do is not resuscitation, at least in my emergency department. A lot of what I do is assisting others to come to their own decisions and empowering junior staff to learn to make simple, straightforward decisions on simple, straightforward cases, because you have to learn to crawl before you can walk. So sometimes residents come to me expecting me to give them the answer, and my reply is, both options you've mentioned sound very reasonable. You've seen and examined the patient. What do you think? And I often get a very glazed over and sometimes surprised look, because they're expecting that I just provide direction and make a decision. So in the resuscitation room, that is okay, but on 99% of what we do in a shift, by simply directing my junior staff, I may not be empowering them to learn to take over this specialty. A very leadership-dominant view on resuscitation shifts a lot of the decision-making and the responsibility to one single person. And for those of us that have been in those positions, it is very difficult to be trying to tidy up all the loose ends and provide direction in very time-pressured situations. The psychologists tell us, and there was a study in this field by George Miller in 1956, that we can really only remember 7 things plus or minus 2. And that work has evolved to talk about concepts of memory slots, and it's all very interesting. But suffice to say, one person is very limited in what they can bring to the table, and they require a team that are engaged and provide their own critical thought. The other thing is that the very leadership dominant view of resuscitation with the leader by the end of the bed doesn't really take into account difference in personality types and perhaps different cultures. The leader standing at the end of the bed is very traditional, but if I'm managing a situation in the emergency department where I may need to intervene, I'm not standing at the end of the bed. So for example, if the resuscitation involves an intubation and I might be my registrar's plan B, I'll be standing on the right side of the patient ready to take over the airway. And what I've increasingly done in the last couple of years is I've had the rocuronium in my scrub pocket, and I will push the sedative and the paralytic. So nothing happens until I want it to happen. And that way I have control. And by standing close to the registrar and inching up towards them, I can then take over if that is what's required. So you need to be flexible, particularly for those of you that work in small teams. Paramedics, there's you and one other. So a very sort of leadership dominant view where one person takes a back seat is not really going to be effective practice in the pre-hospital environment or in rural medicine. And for the followers, there are a few problems. Now, it may seem that I'm down on a very sort of dominant leadership view, but what I'm trying to do is just raise a few questions and allow us to all think critically about what we do. Sometimes it is necessary to simply take over and take control. But for followers, they can be sort of disenfranchised and just sort of go along with what they're told to do and can disengage. And we need followers in emergency medicine to speak up. Team leading resuscitations myself, time and time again, my bacon has been saved by clever, engaged followers, be that nurses, paramedics that have dropped the patient off, or registrars that have actually brought matters to my attention that I can then sort of deal with, because I'm overwhelmed thinking a couple of steps ahead. So I require a team in the resuscitation room to really be engaged and give me some guidance when I'm team leading. So who gets to be the leader in emergency medicine? We work in pretty hierarchical environments, in hospitals at least. And I can only talk about my own experience in my own hospitals. And it's generally based on task competence. So if you're a solid performer in your clinical role, you can quickly find yourself tasked with being the leader in clinical situations and sometimes being leaders of teams. And you may not have had some of the training to do that. So I gave my registrars a bit of a talk on leadership, and I opened with a question, have you had any leadership training? And not one raised their hand. So the pressure was on for my 45-minute talk, which was going to be the subtotal of all their leadership training. But clearly you can't teach leadership in 45 minutes. There is a period of time and apprenticeship in what we do which can't occur in the classroom. And it is relevant to note that all leaders start out as team members. And so being a team member and being an engaged team member is actually your leadership training, all right? So it is not the opportunity to sort of fall asleep at the wheel and become task-focused if you think that you will one day be team leading the resuscitation. No, the resuscitation and being a team member is your training to be a future leader in the specialty. So I guess a few comments just on leadership in resuscitation. Look, and on leadership in general, I mean, the literature debates whether leaders are born or made. I think we can probably agree it's both. If any of you go to Ubud and sit under a tree and think about this issue and find the answer, please let me know. But I think it does require a degree of the right training and the right experience, but that certainly some personality types thrive as leaders in the resuscitation room and in emergency medicine more generally. Leaders need to work to their personal strengths and their personal weaknesses. And it stands to reason that you need to know what these are. So I've had a small amount of leadership training. I don't identify as a leader. And often the leadership training starts off with a period of self-reflection, various activities about what sort of personal strengths and what sort of personal weaknesses that you bring to the workplace. I need to say, and in fact this audience is a sophisticated one in this, but resuscitation is a complex technical task. So yes, you need to be a good leader to manage a team, but you need to be a subject matter expert. So you could not throw a management academic or an admiral in the Navy or anyone with substantial leadership experience in the resuscitation room. They simply could not perform the tasks expected of them, even though they are leaders in their own respective fields and have had more than enough leadership training in general terms. Leadership and leadership in resuscitation is around acquiring and directing others towards those complex technical tasks. So some of my trainees and some of my colleagues, when we discuss their future aspirations, and some of them say they want to be directors of departments, my strong advice is that you have to be a respected clinician. And I have worked with others that have quickly abandoned their clinical roles to take on leadership roles, and over a period of years then struggle when they're back on the floor. And that is always going to be natural. But I think they underestimated how much being an engaged and respected clinician was really the bedrock and foundation of the leadership role that they held. Leadership is about engagement and empowering your team. And this, I think, is particularly important in a teaching hospital environment where we need to encourage and mentor others. Leadership is simply about an empowerment and how you direct that power. It's worth noting that it doesn't need to be particularly pretty or slick, but I think the outcomes are highly relevant and we need to focus on sort of care that provides the best outcomes to our patients. A few years ago, I had a role where I was convening the quality aspect of the local medical emergency team service, and we would review cases. And on more than several occasions, I had team members come to me and express how satisfied they were with the team dynamics and the performance. Yet on reviewing the file, the patient died, and in fact there was several opportunities to do things differently. And conversely, the other side of the coin, people had come to me and said, well, gee, David, that resuscitation was terrible, we need to review it. And on reading the file, everything seemed to have been done properly. So it is about the gloss and the show, but in medicine, it's a lot more than that. It's about the outcomes for our patients. So I think I've sort of covered this. I mean, I've mostly talked about leadership in the resuscitation room, but that's not what mostly we do. I find one of the biggest challenges personally for me in emergency medicine is to shift and pivot from looking after patients that are acutely unwell to looking after patients with sort of categories 4s and 5s that have come to us via the waiting room. And their sprained ankle, of course, is important to them, but I do find it very hard to transition from a complex resuscitation to the low acuity patients. I personally struggle with that. I think a lot of my colleagues do. It's why I think, to use a cricket analogy, I guess Test match cricket and T20 cricket is both cricket. And some truly exceptional players can play across both fields, but some are sort of just one version of the game than the other. So I do kind of stop and think about how I transition in emergency medicine. I find that personally difficult. But it's sort of what we do, all right? We see anyone that's come before us with a problem. And for those of us that are supervising and mentoring junior staff, we do need to provide leadership. So the best colleagues that I work with, and in fact previous sort of mentors and supervisors when I was a trainee, they were respected clinicians. On a shift, they didn't micromanage. I struggle with micromanagers. I think it's a personal weakness. They were approachable to everybody, patients, staff members, and they led by example. And I think leadership is about example setting. And they create, on a shift, a good balance between a relaxed vibe and people actually getting up, seeing patients and being productive. And I've walked into departments where everyone's clearly tense because whoever's looking after the shift can be a difficult person to work with, and I've also been on shifts where people have been kicking back and way too relaxed for the work ahead of them. So it's about striking that balance. When I was a junior consultant, I felt that I probably was never going to be a luminary in this specialty, so I prided myself on being the consultant that would make sure that everyone had their lunch and dinner breaks approximately at lunchtime and dinner time. And that's just what I do. So I constantly direct staff to actually look after themselves and have lunch and dinner breaks. I don't think I had much, as I said, certainly not added much to the academic side of the specialty or perhaps the specialty in general, but the registrars and residents who work with me can at least have dinner when dinner is due. Conflict in emergency departments is universal, and good leaders engage in conflict when that is necessary. They don't walk away from it. Conflict can be an opportunity to resolve several issues, but they are measured and advocate for the right thing to do rather than blindly taking sides. So this is the really important bit of my talk. So this is the concept of followership in emergency medicine. Now, I don't want you to think I've just shit-canned leadership, because leadership is really important. But as I said, I just cautioned that a very dominant view of leadership can impliedly just relegate followership to the sidelines where I don't think it belongs. So followership is not just a one-size-fits-all model. And it's important to note, I think, that in your career, you are very unlikely to cease being a follower. That is, everyone has a boss, mostly. We all have to, when we're in sort of some leadership positions, flip-flop between that position of leadership and that position of followership when we're dealing with others higher in the hierarchy. But, and I think this is uncontroversial, we're not particularly well trained to be team members in the same way some of us have had some leadership training. And being in a leadership position gives you a unique perspective on what a good team member does. So it can be difficult when you first start out to know what is expected of you. And I think good leaders set those expectations. This is probably the most academic slide. The pictures around the edges I just kind of added. Right? It's the middle diagram that's probably the most relevant. And we'll see if this laser pointer works. Ah, beauty. Right. So this is a sort of a model of followership. And over here, we have very passive followers who aren't really focused on the task at hand. And over here, very active followers, very focused on the task at hand. Up the top is those that think critically. Down the bottom is those that do not exercise any critical thinking. And this diagram was adapted from the work of Barbara Kellerman, who's an academic in the field of followership. The pictures around the edges, I think, are the best bit. They're mine. Let's see if the laser pointer works. Oh no, back again. So, those that aren't really focused on the task at hand and don't exercise critical thought, I think they're sheep. All right? Those that are engaged at the task at hand but don't think critically, I thought a minion was the best representation of those people. I found it really difficult to find a picture of someone who exercised critical thinking but was really unengaged at the task at hand. And I eventually settled on Dr. House as someone who I think is really not sort of towing the common line but does think critically. And this is where we want to be, right? We want our emergency departments to run like the F1, right? Those pit stops are absolutely incredible, right? Most of us oscillate in here somewhere and flip-flop from time to time, and I know that I do. I can become engaged, then not engage. I can think critically and let people... It's not only thinking critically, it's letting people know what your thoughts are. I can think critically or I cannot think critically, and I probably shouldn't. I need to be all the way up here when I'm a follower, right? And that's the F1 picture. We all want to be there with our teams. So the model, as I've said, implies that team members need to have the ability to think critically and articulate their thoughts. And to do that, they need to be engaged with the task at hand. And I guess the question that arises naturally is whose responsibility is it to achieve that? Is it the leader or is it the follower? And I think the answer is probably both. All right? So I developed some rules of followership. These are just my random thoughts. So, if you want to kind of quote this talk, just say some guy in Bali told me, all right? There's no real academic reference to this, but a few collections of sort of loose thoughts. There's 7 rules, so just bear with me. As I said, I promised to have you out to the beach clubs by 4:30. Be situationally aware. I don't know how well that projects or how you can read at the back, but this is a quote by Wayne Gretzky, world famous hockey player, and he says that he skates to where the puck is going to be, not where it has been. All right? So situational awareness as a team member is about a sense of anticipation as to where the resuscitation or, in fact, any task at hand is heading, and how to sort of position yourself so that you're in the right position, the right frame of mind to deal with what's required of you. We accept, and it is very commonly taught, that team members need to speak up when something isn't right. And there's been numerous instances, and indeed very tragic cases, where teams have been overly task-focused and then lead themselves into error. The psychologists tell us that if most of the group think about a particular solution to a problem, individuals that think differently may actually even go along with the group consensus, even if they know that to be wrong. And there's been numerous experiments that would prove that. So just because the group and the majority think one thing, in this instance, democracy isn't necessarily right. It may well be. Now think back to my comment about how individuals can only retain about 7 facts in their short-term memory. Means that when I'm team leading a resuscitation, I'm constantly overwhelmed with trying to think several steps ahead. And I'm forever grateful for people in the room that want to speak up, particularly as to fact. All right? I'm probably, to be honest, a little less interested about whether the intern or the medical student thinks I should intubate the patient. And I'll try and deal with that as kindly as I can in the heat of the moment. But I'm very interested if the intern walks into the room and says, "Are you aware the saturations are 85%? Or are you aware the patient is blue?" That is speaking up as to fact rather than opinion, and that is very welcome. And chances are I might acknowledge that and say, yes, I'm aware of that and we're trying to resolve this. But I think it's very important that people in our teams are engaged and have the permissions to speak up, particularly as to fact. In the less acute setting, I find it curious sometimes when some of my really quite clever junior staff spend an hour taking a history and examining a single patient and aren't sure, and then believe that I can just solve the problem in 60 seconds without seeing the patient and perhaps by flicking through some blood tests. I probably can't do that. And so I do rely on what history and examination comes from that person who's originally assessed the patient. As I said at the beginning, I do medico-legal work, and I can't emphasise enough the number of times I've seen problems where the simple things aren't done properly, like a good history and a good examination, and those simple things haven't been part of the series of facts and premises that have then informed the decisions that need to be made. So do speak up, and it is important that team members are engage. And often in the non-acute setting, it's that team member that has actually taken the history and done the examination that is in an excellent position to advise and work collaboratively with a specialist about what the ultimate disposition should be. That's rule 1 done. Be situationally aware. I mean, this just has to be one of the greatest sporting quotes of all time, doesn't it? So Muhammad Ali, float like a butterfly, sting like a bee. So float, all right? And I think what Muhammad Ali was talking to was just being poised in a cat-like state of readiness, ready to pounce. Well, perhaps a butterfly state like of readiness, and be ready to sting like a bee. So that, to me, means perform tasks with purpose and efficiency, but remain light-footed and poised and be ready to be redeployed with a moment's notice. That's rule 2. So this is a quote from Aristotle. I wanted to infuse a little bit of culture into this talk in case any of you get ordered by the tax office and need the slides. All right, so there's a comment from Aristotle that says, what we repeatedly do, we are what we repeatedly do. Excellence then is not an act, but a habit. So rule number 3 for teams is excellence is the real goal. And I'll explain what I mean. So I think it is about providing truly excellent care. I think patient safety is really important. I do wonder whether that can constrain a view sometimes that it is excellence that we aim towards. So most of us have been to patient safety seminars where there's been several slides of aeroplanes that have clearly sort of not landed on the runway, and then captions about how many jumbo jets full of patients die each year from preventable errors. And I don't want to underestimate how important patient safety is, but we can impliedly hear the message that our job is to simply not kill the patients. And I think it's a little bit more than that. So I think really excellence has to be the goal, and if excellence is the goal, then patient safety comes along with that. As I said, not being critical of patient safety and those sorts of talks, not being critical of any of the dominant thoughts in the specialty, just wonder whether we can reconfigure things a little bit by focusing on excellence. And I think it has to be said that excellence is not necessarily resource dependent. Now, outcomes might be resource dependent, and that makes sense. And there's a saying that geography is everything in emergency medicine, and I think some of us have heard that and we think that that's partially true. But just do the best with what you have and make excellence your goal, and don't give up when faced with obstacles. All right, that's rule 3. I told you I'll have to get to the beach clubs by 4:30. So a quote from His Royal Highness, all right? Talents win games, but teamwork and intelligence win championships. So rule 4 on my list of followership rules is defer to true excellence. And I'll just explain what that means. So everyone in this room won't argue with the concept that emergency medicine or pre-hospital care or rural hospital care is a team sport. Everyone has different talents and experiences to bring to the situation. But sometimes expertise does exist outside of the emergency department or outside of our specific environment. And it becomes a challenge for experienced providers to know how to leverage that expertise. And sometimes experienced emergency medicine providers end up having to be followers when specific expertise enters the room. So that perhaps, an example could be a difficult airway when a very, very experienced anaesthetist enters the room. And that situation requires a little bit of skill as to how to integrate that true expertise into the team. We clearly don't want to abdicate our role as team leaders and our role in managing the patients to people with specific technical expertise, but it is a true skill of a leader and a follower, and therefore of teams in resuscitation, to know how to integrate that true expertise. And so sometimes individually for team members, when you are tasked with doing something that may be difficult, it becomes a judgment call as to whether to attempt to perform the task or suggest that someone else would be better suited. And so some sort of reflection and some sort of true understanding and engagement of the situation at hand will inform whether it should be you performing that task or whether that should be delegated to someone either in the room or outside of the room. So that's rule number 4 of followership: defer to true expertise. Close the loop. So a quote from George Bernard Shaw: the single biggest problem with communication is the illusion that it has taken place. And how true is this? So those of you that have been around for a while in acute care have some concept of what closed loop communication is. But if you'll just indulge me a couple of moments to make a few comments and bring everyone up to speed. Closed loop communication is essentially issuing a read receipt for the task that you have been instructed to do. So fast food providers do it. You order coffee at a cafe, restaurant, you get your order read back to you, and that you're clear. Closed loop communication is not simply just speaking into the ether, rock uranium in a very soft voice. Closed loop communication is much more directed at the person giving you that instruction. And we need to communicate amongst our teams. A previous mentor of mine had once told me, he said, David, he goes, in all these years, I have never been accused of over-communicating, all right? And so communicating in specific ways is a very important part of being an effective team member in critical care medicine. You've got 2 more rules to go. So that was rule 5, close the loop. So this is rule 6, and I can say a lot here. You need to acknowledge that as a team member in a high-stakes field like healthcare, and particularly emergency medicine or critical care, that you are not a robot, all right? And a quote here that you've all heard before, I'm sure, is that you can't pour from an empty cup. And I'll make some comments if you'll indulge me. So you require a degree of self-care to perform well as a team member. And that takes there's a mixture of personal and organisational responsibility here. But as a team member on a busy shift in the emergency department, I tender that you need to manage your own hydration and you need to manage your own toilet breaks. And as a leader, it is very difficult for me to do that. So I would encourage you on a shift to take reasonable breaks. As I said before, I pride myself in being like the dinner guy, ensuring that everyone gets dinner approximately between the hours of 6 p.m. and 8 p.m. But I think that requires a little bit of individual responsibility to achieve that. I know this is not a wellness talk on emergency medicine. I mean, that's a specific talk in itself, and it's a very, very important concept. But just be a little bit aware that there's an implied message in wellness that work is bad and time away from work is good. All right? I think we need to look for meaning, and you can Google the happiness paradox. And I think it's worth noting that I think meaning in what we do is important. I mean, and you guys, you know, you're in Bali, you're in paradise, you're on a tax-deductible holiday. Other than listening to me, you're doing everything right in the sort of wellness space. So these sorts of meetings, these sorts of gatherings and conferences where we share information and express solidarity are really important, all right? And your career in emergency medicine is not a sprint, it's a marathon. So do look after yourselves and do acknowledge when you need time out from the situation, either momentarily or sort of as a more sort of short to medium term view. So that's rule 6. You are not a robot. Rule 7, evolve. And I'll explain what this means. I don't think you'll be able to read that, but look, I've just poached off the internet a quote from Warren Buffett. In fact, I can hardly read it on the computer here, but he says, "It is good to learn from your mistakes, and it is better to learn from other people's." And a quote here from Kanye West, so proof that even a stop clock's right twice a day. Kanye says, "You're not perfect, but you're not your mistakes." All right? So this is just a couple of comments on professional development, on learning, and on self-reflection as part of being a team member. So we depend on future leaders in emergency medicine. I hopefully will one day retire. Perhaps I'll be a patient in my own emergency department. It's important that team members evolve and self-reflect and learn. So sometimes things don't go according to plan in what we do, and I think true self-reflection is important. It's not just sort of asking yourself, why did this situation occur? It's asking yourself, what role did I have in that situation? So the question becomes a little bit uncomfortable sometimes, but I think that's because self-reflection can be uncomfortable. So if there are errors, if there are problems, think about what the learning points were. Talk to your colleagues, talk to your peers, talk to the resuscitation team leader. I think those conversations are really important. So I really appreciate it when I have staff come up to me and they say, "Look, I noticed you did this, why did you do that?" And I'd like to think on the majority of occasions I can justify why I did what I did. And I think I can, and that can provide a moment of teaching and learning. And then I can at least explain what I did so that I hope that the member of staff doesn't go home thinking I'd made a hash of it. I can actually explain what it was that I did that allows and facilitates a degree of learning and self-reflection amongst all of us. I think that's important. And think about, for those of you that are team members, think about the sort of leaders you want to be in emergency medicine, and accept that being a team member is your training ground, and take the best bits from the supervisors that you work with. Reject the bad bits. Don't follow practice that you think is unhelpful, but constantly pluck little nuggets of practice that you think are important. And that's what it's like to evolve. So self-reflection and be aware of the circumstances you find yourself in. So to summarise, so these are Banfield's 7 rules for followership. As I said, could be cited preferably as some guy in Bali told me. But be situationally aware, be ready to sting. Excellence is the goal. Defer to true expertise. Close the loop. you are not a robot, and evolve. I'll provide some concluding remarks for 2 minutes, and then we might have an opportunity for 1 or 2 questions. So providing excellent care in healthcare relies on appropriate team dynamics. I think good leadership is absolutely important, but I think we just need to be aware that a focus on leadership can be at the cost of not appreciating how important it is to be a good team member. Think about the sort of leader that you want to be. Think about the sort of team member that you want to be. Don't ever be passive in whatever role that you have. Be engaged with the task at hand. Think critically and articulate your thoughts. And look, think about my 7 rules. Maybe they'll come in handy one day. I think I've left 5 minutes for questions, which is perfect, because hopefully I only get 1 or 2 and they'll be pretty simple.
Thank you, David. Any questions for David before we wrap up? Perfect.
Sounds good.
Thank you very much, David. That was really insightful. A lot of things that we can take with us professionally, but also personally. Particular note and worthy mention is aggressive tax deductions. So thank you very much.
Yeah. Thanks, man. Appreciate it.
And that brings us to the concluding part of our day 1 session at Bali EMS Conference. So well done, everybody. It's been wonderful, and I think today was a really great success. Just a couple of notes for the rest of the week before we wrap up. There are a couple of spots. There's 1 spot, in fact, for the wounds and suturing workshop on Thursday. And there are 9 spots for the ECG workshop. So if you are interested, scan the QR code on the back of your name badges and click on the links in that book. We also have space for breathwork and yoga on Thursday and Friday mornings, if that tickles your fancy. I did the breathwork this morning as a novice, and I can, whilst I did fall asleep in it, I can confirm that I did feel revitalised after the fact, so I can recommend. Tomorrow we'll kick off. It is our early morning, so we'll kick off at 7:30 a.m. sharp tomorrow back here in this conference room. Tea, coffee and breakfast-themed canapes will be available from 7 a.m, as will our wonderful massage therapist staff from the Trans Resort be available for 5-minute shoulder and neck massages from 7. So I look forward to seeing you then. Otherwise, have a really wonderful evening. You are welcome to hang around and collaborate, but have a wonderful evening. Enjoy Bali, enjoy Seminyak, and good night and thank you.